It's important that the goal of frontline treatment of ovarian cancer, including surgery and chemotherapy, is long-term disease-free survival, tumor control, if you will. It's not enough to help a patient live, you have to help her live well. And it all starts with a complete resection and a surgery. This patient didn't have that, but she did have an operation. It begins with good chemotherapy, which is intravenous carboplatin and paclitaxel. This woman had intraperitoneal chemotherapy. Intraperitoneal chemotherapy is not better, it's just more toxic. And the goal, again, is long-term disease-free survival and symptom-free survival, survivorship, if you will. The average time to progression would be maybe 15 to 20 months. As I said, patients with a BRCA mutation can even do better than that because BRCA mutation portends an improved prognosis. The other thing that's interesting about her is that she should have breast screening, probably breast MRI, doesn't necessarily need a risk-reducing mastectomy, and her family members should be tested because that's the cure of ovarian cancer. Identifying family members who have the genetic mutation and doing a risk-reducing surgery, which is removing the ovaries and fallopian tubes at the end of childbearing, but before the risk increases for ovarian cancer, maybe before age 40, and that's the Angelina Jolie effect. Angelina Jolie's mama died of ovarian cancer, but she won't because she was tested for BRCA and had a risk-reducing operation. One of the questions in the frontline management of advanced ovarian cancer certainly is intraperitoneal versus intravenous chemotherapy, and we touched on that we basically live in an IV world, not an IP world, intravenous. But also, should targeted therapy be added to frontline treatment? As you may be aware, in 2011, we published in the New England Journal, GOG 218, Protocol 218, Robert Berger was the first author. We showed an improvement in progression-free survival, and that led to approval around the world of frontline bevacizumab. It was never submitted to the US FDA for frontline approval until August of 2017. It has a PDUFA date, a due date in June. So we eagerly await the FDA's decision as to whether or not bevacizumab should be added to frontline chemotherapy, and it's not just during chemotherapy, also in maintenance, for a total time of 15 months, which is the average time of time to recurrence. We eagerly await the FDA's decision because I think certainly that will change reimbursement. Currently, maybe 20 to 30% get frontline bevacizumab off-label, but it's likely that that will increase with the approval should it happen. And the due date, the PDUFA date, as we say, is June 25th, 2018.